What if the test your doctor ordered is actually putting you at greater risk than the condition it was looking for? This is a conversation leading physicians have been having for years, and most patients over 70 never get to hear it. Here's what changes after 70. Your body responds to medical procedures very differently than it did even a decade ago. Your kidneys filter contrast dye more slowly. Your heart handles sedation with less reserve. Your recovery window has changed. And your immune system recovers from biopsies at a fraction of the speed it once did. That changes every calculation. Not to tell you to refuse care, but to give you the questions your doctor may never think to ask you first. The last 18 of those years have been dedicated almost entirely to the care of patients over the age of 65. I want to tell you about a patient of mine, Chero. I'll call him Harold, 74 years old, a retired school principal from Ohio. Harold walked 3 miles every morning, ate well, took no medications, and felt better than most men half his age. He came to me not because something was wrong, but because his annual physical had flagged a mildly elevated PSA reading. His previous doctor referred him for a prostate biopsy as a routine next step. Harold assumed that if it was ordered, it was right. What no one had explained was that at 74, with no symptoms and no family history, that biopsy carried real procedural risks, and a high likelihood of detecting something that would never harm him in his lifetime, setting off a cascade of further interventions. I'm going to walk you through 5 of the most commonly ordered tests in seniors and why the risk calculation changes significantly after 70. A landmark analysis in JAMA Internal Medicine found that a substantial portion of procedures in older adults fall into the category of low-value care. The good news: being informed doesn't mean refusing care. It means becoming a more effective partner in your own health decisions. Knowing which questions to ask and when to request a second opinion, that knowledge could genuinely change the outcome of your care.
Tell me about the second opinion.
For younger men, PSA testing has played a meaningful role in catching prostate cancer early. After 70, the picture changes completely. Test number 1, routine PSA screening after 70. Most people assume more cancer screening is always better. That assumption has a real cost. Think of it like a smoke alarm that goes off every time you make toast. Not wrong exactly, but not the emergency it appears to be. A study in the New England Journal of Medicine found that PSA-detected cancers in men over 70 were largely tumors that would never cause symptoms or death. Meanwhile, the biopsy itself carries real risks: infection, bleeding, urinary complications. Test number 2, routine colonoscopy after 75. For adults between 45 and 75, but after 75, the math changes. Cancers found through routine screening at this age are mostly slow-growing adenomas. That growth window exceeds the realistic risk horizon for most patients in their late 70s and 80s. The expected benefit shrinks considerably. At the same time, procedural risks rise. Bowel perforation becomes more likely, and the prep can cause dangerous Test number 3, asymptomatic carotid artery ultrasound. This one surprises people. The scan itself is harmless: no radiation, no sedation, no needles. The American College of Gastroenterology says routine screening should generally stop at 75 for average-risk individuals. Most people assume finding a blockage early means fixing it early and preventing a stroke. That logic seems sound. The evidence says otherwise. The intervention that typically follows, surgery or stenting, carries a procedural stroke risk that in many patients approaches the very risk it was meant to prevent. Think of it like calling a repair crew with a 3% chance of knocking the wall down. For many seniors over 70, that math simply doesn't work. A major analysis in JAMA found that for asymptomatic patients, the absolute benefit from surgery is small. My recommendation: if colonoscopy is being proposed after 75 with no symptoms, ask your doctor to walk through the benefit. The U.S. Preventive Services Task Force recommends against this screening in the general adult population. The evidence does not support routine use. My recommendation: carotid ultrasound makes sense when you have symptoms. Without symptoms, ask what the plan would be if something is found. Is there someone in your life, a parent, a spouse, a sibling, scheduled for one of these tests without fully understanding the risks involved? And if this video is giving you something your doctor's office never took the time to explain please hit the like button right now. It tells YouTube to put this in front of more seniors who need to hear it. That one click reaches people who are looking for exactly this. Test number 4, DEXA bone density scans, and what happens after. The scan itself is low risk. The concern is what frequently follows the result. Most people assume that if a scan shows osteopenia, the stage before osteoporosis, treatment should begin right away. The concern is bisphosphonate medications like alendronate PRAUs, prescribed without adequate assessment of actual fracture risk, kidney function, or its. In many cases, this is a normal feature of aging, not a disease state requiring pharmaceutical treatment. Think of it like reading a slightly low tire pressure and immediately replacing all 4 tires, without checking whether any of them actually need replacing. My recommendation: ask your doctor to calculate your FRAX score before any medication is started to have, and ask about resistance exercising. Bisphosphonates carry a small but real risk of osteonecrosis of the jaw, where bone tissue dies, particularly. They also carry a counterintuitive risk of atypical femoral fractures, unusual thigh bone breaks with use beyond 5 years. In patients over 70 with reduced physiological reserve, these risks are meaningfully higher. The body has far less margin to absorb that kind of imposed stress. Pharmacological stress tests, using agents like dobutamine or adenosine Halder, carry risks including arrhythmia, dangerous. Test number 5, TIVE, routine cardiac stress testing in low-risk, asymptomatic seniors. When symptoms are present, stress testing is average. False positives are also common in this age group, especially in women and a false positive leads directly to cardiac catheterization, contrast nephropathy, arterial injury, bleeding complications. Think of stress testing a bridge not because of structural concerns. The American College of Cardiology advises against routine stress testing in asymptomatic, low-risk patients. If the honest answer is we would probably just watch it bow, that is important information. You deserve to hear it before the test, not after. Most people assume stress testing is a smart, proactive way to monitor heart health as you age. Without clinical indication, let's bring this together. We covered 5 tests: PSA screening, colonoscopy after 75, carotid. In every case, the message is the same. Ask better questions. What will this test find? What do we do with that finding? What are the risks for my age? Research in the Journal of the American Geriatrics Society shows that seniors who engage in shared decision-making experience fewer. That video could be the most important one you watch this year. Subscribe and hit the bell right now so you don't miss it. The person who needs this most is probably not looking for it, but you can put it in front of them. That share could genuinely change the outcome of someone's care.